Hello. Extubation after general anesthesia may be associated with many complications like requirement of patient not able to maintain the airway, requirement of reintubation, etc. Now, I have been taught that when you are in doubt whether to intubate or not to intubate, you should rather intubate. And when in doubt whether to extubate or not to extubate, rather not extubate. So, extubation is an elective procedure. It has to be planned properly. It cannot be done in hurry or it cannot be done in emergency. And for every patient whom you intubate, as you plan for the intubation strategy, similarly, we need to plan for extubation strategy also, thinking about all the risk factor the patient may have and all the problems which may patient face after extubation, depending upon the type of surgery, depending upon the comorbidities, etc., present in the patient. Now, in this section, we will talk about those extubation strategy along with a case. So let's start with discussion of the case. Now, the case is a 52 years old patient with body mass index 35 and a diagnosed case of obstructive sleep apnea. He was operated under general anesthesia for thyroidectomy. Thyroid mass was long standing with a size 6 into 8. Awake fiber optic was done and 8 internal diameter tube was secured. The surgery lasted for 2.5 hours and was eventless. Now, how do we plan extubation of this patient? So, to discuss about the plan of extubation, we need to know that what are the complications which can be associated with extubation and how do we stratify the risk of these complications in an individual patient so that we individualize the approach of extubation. So let us start our discussion with the complications which we may face during extubation. The complications can be divided into three sections. The complication due to the physiological response of extubation, the complication due to patient not being able to maintain the airway, inability to tolerate the extubation, airway and oxygenation after extubation, and the difficulty in reestablishing the airway, complication due to difficulty in reestablishing the airway. So, under these three headings, we'll discuss the complication. Let us start with the physiological effect of extubation. So, what are the physiological effect? Physiological effect of extubation which we may face, and what are the patient who are at risk of these physiological responses which we see during extubation. So patient is gradually being is awake and I need to remove the endotracheal tube. So patient is awake with ET tube, and if we not blunt the sympathetic response at this point of time, that there is a possibility that patient will have a sympathetic stimulation resulting in increased blood pressure, increased heart rate, increase let's say intracranial pressure, coughing, bucking in the patient on the tube would lead to increased intracranial pressure, increased intraocular pressure, patient moving violently. Now, this may be very well tolerated by a normal individual, but patient at risk like cardiac patient or patient let's say carotid patient who has been operated for the central nervous system surgery, neurosurgery, or carotid surgery, or patient in whom we don't want any movement, let's say flap surgery, or patient ocular surgery and we don't want the intraocular pressure to increase. These are the patients who are at risk and may develop problems when these physiological response would come. So we need to blunt these responses. I'll talk about the medications when we extubate, what medication we can use to blunt this physiological effect of extubation. So what physiological effect are due to? It's mostly due to sympathetic stimulation which a awake patient has on the noxious stimuli, which is the tube. So sympathetic stimulation, and this sympathetic stimulation will produce increase in blood pressure, increase in heart rate. It can cause coughing, it can cause bucking on the tube, it can cause agitation in the patient. And all this coughing, bucking and agitation would increase intracranial pressure and can increase intraocular pressure. So who are the patient at risk? Patient at risk. Now, patient at risk are the patient who are having some cardiac comorbidity, or patient with cerebrovascular disease, right? Cerebrovascular disease, or patient being operated for neurosurgery or ocular surgery, or patient in which flap surgery was done and we don't want the patient to move. These are the patient at risk. In them, we need to blunt this physiological effect of extubation. Now, the second group of the complication is the patient in patients who have inability to tolerate the extubation. So, what are the patient who may not tolerate the extubation, and we need to identify them from beforehand, take the measures, and maybe go for an interval extubation if patient is not immediately ready for extubation. So we need to first identify the patient who are at the risk of not tolerating the extubation. So patient inability to tolerate extubation. Now the patient who are at risk of airway obstruction. Now airway obstruction because of the laryngospasm which developed, or laryngeal edema, a surgery near the larynx, or intraoral surgery resulting in laryngeal edema. Then airway swelling after laryngoscopy or prolonged intubation. So during intubation, we took a long time and we are suspecting a airway swelling, right, prolonged because of the prolonged attempt which we took. Then macroglossia. Now patient was in a Trendelenburg position for a long time, or let's say a sitting position, which could have led to the increased fluid accumulation in the oral cavity and the subcutaneous tissue of the oral cavity, and soft tissue swelling, etc. has taken place, macroglossia. Then postural changes after neck surgery, that is wound swelling, hematoma, recurrent laryngeal nerve injury or hypoglossal nerve injury. So after thyroid surgery. Now these complications we can expect. Then obese patient with a history of obstructive sleep apnea, they are unable to sometimes maintain the tone of the upper airway muscles. Then patient with Parkinson disease. Now in patient with Parkinson disease, there is incoordination of the vocal cord movement seen in them, right? So because of this, they are at the risk of aspiration. Because of this, they are at risk of desaturation. Then patient with rheumatoid arthritis. In patient with rheumatoid arthritis, the neck joint, or the let's say the arytenoid joints, they may be fixed. Now because of this fixation of the joints, there is a possibility that the proper let's say airway is not maintained, airway obstruction may happen. Then paradoxical vocal cord motion. In some patient, after some surgery, paradoxical vocal cord motion has been observed, and it has been let's say diagnosed improperly, like in a patient not getting managed because of bronchial asthma, that is unmanageable bronchial asthma. By mistake, the diagnosis has been made for the paradoxical vocal cord motion as unmanaged bronchial asthma, because in paradoxical vocal cord movement, diagnosis is really difficult. So you need to have a high index of suspicion to diagnose it, and need to know the patient who are at the risk of this, right? So these are the patients who are unable to tolerate the extubation. Apart from this, patient in whom there is a chances of inadequate ventilation, they will not maintain the oxygenation. The patient who are under the residual effect of neuromuscular blocking agent, residual sedation, undully sensitive patient, and has received the anesthetic agent for a long time and are still very much deep under anesthetic agent. So diaphragmatic splinting because of pain, we have not given a very good analgesia, and because of this, there is a possibility that diaphragmatic splinting is happening. Then central sleep apnea, severe COPD, patients increase CO2 production, but because of, let's say, fever, post-op develop or shivering, so increased CO2 production because of hypermetabolism, neuromuscular disease, all this would make inadequate ventilation. Then inadequate oxygenation, the patient already having the pre-op pulmonary complication or pulmonary comorbidity, and after GA, the basal atelectasis has increased. So post-operative atelectasis has reduced FRC, extremes of age also. Insufficient FiO2, then increased metabolic demand, post-obstructive pulmonary edema, the negative pressure pulmonary edema, chronic lung disease, pulmonary vascular disease, interstitial lung disease. Now, failure of pulmonary toileting. Patient doesn't have a good consciousness level, so unable to cough and take out the secretion. Now, and or for some reason the secretion is very high, high amount of secretion coming. Inability to protect the airway. Again, consciousness is not good enough. Neuromuscular disease, all airway swelling, all this would make difficult for the airway to remain protected. So, inability to tolerate extubation due to airway obstruction, due to inadequate ventilation, due to inadequate oxygenation, failure of pulmonary toileting, and inability to protect airway should be predicted before extubating the patient. So, if these conditions are present in the patient, we need to optimize the patient for these conditions and then plan the extubation. Or, if immediate optimization is not possible, we can plan for an interval extubation. Now, the third group of complication is because of the difficulty in reintubation, right? Difficulty in re-establishing the airway. So there could be multiple reasons for which there could be difficulty in re-establishing the airway. Now, anatomic challenge. When we took the patient already was predicted to have a difficult mask ventilation or difficult supraglottic airway device insertion or difficult laryngoscopy and intubation or difficult front of neck access. So, if patient has pre-op difficulty in intubation, now to re-intubate the difficulty would definitely increase. If patient had a normal pre-op airway, no difficulty anticipated, then also it is not a guarantee that re-intubation would be easy. I mean, intra-op and a lot of other complication, fluids, etc. may have made the airway difficult. But if patient already had a difficult airway previously, then definitely the re-intubation will be difficult, and we need to be prepared for that kind of patient in a more conscious manner. So, anatomic challenge. Doing multiple attempt device operators during prior laryngoscopy, airway edema due to prolonged Tellendenberg or prone position significant fluid balance can lead to the airway edema. Then post-surgical distortion after major head and neck surgery, airway trauma, maxillomandibular fixation done. So, number of time after surgery, mandibulomaxillar fixation done. Now, reintubation is next to impossible. Cervical immobilization or instability. Then physiological challenge. Patient is hemodynamically unstable, so we cannot go for prolonged laryngoscopy attempts. Risk of hypoxia is high, risk of hypercapnia is high. There's already a acidosis present in the patient, so we cannot go for prolonged re-intubation attempt in these patients. Then contextual challenge. The case finished at 7 o'clock in the evening. The senior consultant and other help are not in hospital. So maybe as a resident alone, I would not take an attempt to extubate because the surgery had lasted very long. We have given a good amount of fluid. The risk is there. So maybe an interval extubation would be better. So again, I am saying whether you are in a dilemma, whether to extubate or not to extubate, don't extubate. We can extubate tomorrow in like surgical ICU in presence of consultant after optimization of the patient. Things would be better for the patient. So inadequate knowledge of prior airway difficulty. Maybe the emergency team took over the case after 6 o'clock and they didn't know what was the case airway of the patient prior. Then insufficient equipment or medication in evening. A lot of things are not available. Lack of qualified personnel. Then time pressure. Now all this can make the reintubation again very difficult. So we need to assess for all these factors and plan our extubation. So how do we plan the extubation? Now, as I said, extubation should be planned in an individualized manner for every patient. And there are various societies which gives different recommendation for the extubation. They give the flow chart and protocol for the extubation like we have. For extubation strategy, we have the DAS difficult airway, the DAS extubation criteria, that is the which I will talk about. This is a difficult airway society DAS extubation criteria. So DAS guideline, okay. So we'll talk about DAS guideline for extubation. Now, DAS guideline for extubation strategy incorporates a dichotomous kind of strategy, that is at risk, not at risk. So they have divided their extubation strategy in two groups. the patient who are at risk, the patient who are not at risk. And other society also, apart from DAS, we have ASA task force giving recommendation for extubation. Then we have Canadian Airway Focus Group, Airway Focus Group, Airway Management Guidelines, Airway Management Guidelines. Then we have a lot of other guidelines of different societies as well. Now, all these published guidelines, they when they plan for it, they discuss about the extubation strategy. The first thing which is recommended by them is to identify the patient at risk. So the risk stratification is most important. The risk stratification is most important. So how do we stratify the risk, whether the extubation would be difficult? So extubation risk stratification involves two things we have to assess. Number one, the likelihood that patient will not tolerate the extubation. That is the list which I gave in the beginning. Does any of that, the factors of that list is in my patient, and the predicted difficulty with reintubation. If patient has any of this, any one of this, then we would go for at-risk extubation guideline. We will consider at-risk patient. And if patient doesn't have any of it, then they are a low-risk extubation criteria. We will follow low-risk extubation guideline. Any one of it, at risk, both at risk, right? And as both are present, the risk would further increase. Getting my point? So we have to rule out the presence of any likelihood the patient will not tolerate extubation or predicted difficulty with reintubation. Now, apart from this, there are some patient factors and some surgical factors also that we need to see. So if you see this dictomous plan of extubation given by the Difficult Airway Society, what is this guideline? First is we have to have a plan, assess the airway and the general risk factors, right? Then prepare, that is optimize the patient and other factors, whatever factors you can optimize, you optimize it. Then risk stratification, then we have to assess the risk. Low risk, at risk. So at risk means they will not tolerate extubation. There is a possibility they may not tolerate extubation, or or presence of difficulty in reintubation. Low risk, uncomplicated airway, no general risk factor, good fasted patient. At risk, ability to oxygenate uncertain, reintubation potentially difficult. So if patient is low risk, we go for low risk algorithm, which I will discuss. At risk, we'll go for at-risk algorithm if we plan to extubate, and then shift the patient to ICU. So step one is plan the extubation. Prepare for extubation by stratifying the risk in the patient. Perform the extubation according to the protocol of low risk or high risk algorithm, and then post-extubation care. So this is how we have a extubation strategy, and every patient is an individual patient. This strategy should be individualized according to that patient. Okay, so what are the risk factors which we need to see apart from what I have discussed? What are the other risk factors that we need to see? Okay, so the other risk factors which we need to see is, let's say, obesity is present in the patient or not. So risk factors for extubation failure. Number one, whether obesity is there or not. So obese patient, then association of obstructive sleep apnea, then association of Parkinson disease, then association of rheumatoid arthritis, right? That is cricoarytenoid and cricothyroid. The joint may be fused or fibrosed arthritis. Then paradoxical vocal cord movement, right? In paradoxical vocal cord movement, if I make a diagnosis pre-extubation, I will always go for deep extubation, because when the patient is awake, the movement of paradoxical movement would be even more problematic. So deep extubation, maybe I would be able to extubate the patient. Then high risk surgical procedure. High risk surgical procedure. So surgical procedure which could have made the airway difficult. So thyroidectomy, your carotid end artery surgery, endarterectomy. So thyroidectomy, right? So your carotid endarterectomy, carotid surgery, the cervical spine surgery, right? Or any oropharyngeal surgery, let's say post-op bleeding in the airway, post-op bleeding, or let's say which has led to dynamic airway, which can lead to dynamic airway collapse, or lot of fluids intraop we have given to a patient, or the surgery in which there was a prolonged time period in which the Lendenberg position was made, or surgery in which we are expecting the airway swelling to happen. If any of these factors are present, they are the risk factors for the extubation failure. That's the risk factors for extubation failure. Got my point? So how do we manage the extubation, management of extubation? The first three complications, again I will repeat, which we need to remember. Three complications of extubation which can happen at extubation: the physiological response. Second, whether the patient may not maintain the oxygenation, ventilation after extubation. And third, difficult reintubation. So first, that physiological response during extubation. We can minimize this physiological response by number of interventions which we can do. A lot of pharmacological drugs can minimize that sympathetic response, can blunt that sympathetic response. So minimizing 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 physiological response. Physiological response. So how can I minimize physiological response? There are number of drugs which we can use. Now the most important drug number of times used is lidocaine. Lidocaine. So lidocaine we can give topical lidocaine. We can just have a topical spray of lidocaine. We can give IV, or we can instill lidocaine in the cuff, and the aqueous or non-aqueous lidocaine can diffuse out of the cuff and can give us a better tolerance of the tube, right? So studies have shown that if lidocaine is used to fill the cuff, then it creates a better tolerance of endotracheal tube. So coughing, bucking, etc. will be less. But if I want to have an immediate effect, then I would definitely go for topical or IV lidocaine. The dose would be 1.5 milligram per kg body weight if I am giving it intravenously. We can go for low dose opioid before extubation as well. The opioid has antitussive effect, so a coughing, bucking can be prevented. But low dose, remember, low dose. So low dose opioid because of its antitussive effect. And most common opioid which is used for this is remifentanil, the short acting opioid. Then we can go for dexmedetomidine. Dexmedetomidine. Now dexmedetomidine is a very good drug which is a sympatholytic drug. It is a sympatholytic because it is acting on alpha-2 adrenergic receptor, which is present on presynaptic, on the presynaptic fibers. So they decrease the noradrenaline release at the level of the junction. So they are sympatholytic. So dexmedetomidine, being a sympatholytic agent, would decrease the blood pressure, decrease the heart rate, and also decrease the cough. The low dose dexmedetomidine started just before extubation definitely helps. So dose which has been used and various study for extubation is 0.5 microgram per kg on bolus or infusion over, let's say, 60 minutes. Then something called esmolol we can use. Esmolol, a beta blocker. So esmolol 1.5 to 2 milligram per kg body weight before extubation. It's a short acting agent, so we will be safe. Then we can go for no touch technique. No, I will not stimulate the airway. I will let the patient breathe and gently I will remove the ET tube. So that's a very good technique in a let's say silent room. You are without maximum stimulating the patient, you are extubating. So we go for something called no touch. So no touch, right? So with minimal minimal possible minimal possible extubation, right? Okay. In this, patient should be adequately reversed for neuromuscular blocking agent and should be just adequately under the sedation, not too much uh, deep. Okay, then something called Bailey's maneuver we'll talk about. Bailey's maneuver, which we practice in at-risk patient. Okay, so Bailey's maneuver can also minimize the physiological response, because in Bailey's maneuver we are replacing the more noxious airway device, endotracheal tube, by supraglottic airway device, and supraglottic airway device are very easy to tolerate and they cause less minimal sympathetic stimulation. So number of patient at risk, we use Bailey's maneuver. Okay, so these are the maneuvers by which the physiological response can be minimized. Okay, now we have started. So this has to be done in every patient, because every patient are at the risk of this physiological response. Now we have stratified the patient according to the risk in two groups: the low risk and high risk. So low risk is first what we will discuss. So low risk patient, we do not have, we have not found any reason that when we extubate, the patient would not be able to maintain his airway, would not be able to maintain his oxygenation and ventilation, or would aspirate. They are the low risk. And there would be no difficulty in reintubating them also if we need to reintubate. So they are the low risk. So once I have stratified the patient is low risk,